The aim of this paper is to analyze the end-of-life decision-making process regarding young children who are terminally ill and with no prospect of recovery, from both an ethical and legal perspective. I'm going to analyze a few UK legal decisions, and I know that my audience has a variegate background, so I'll do my best to be not only digestible, but hopefully engaging. But feel free to interrupt me. It is undeniable that nowadays the incredible and amazing development of modern medicine is reflected in new life-saving techniques, medicines, and devices. Usually when it comes to the withdrawal or withholding of life-sustaining treatments in young children, the main actors in the deliberative process are the parents or legal guardians and the medical team, who usually work together towards the welfare of the child. Unfortunately, sometimes there are disagreements, and here, when these occur, the next level of scrutiny is going before a court. The main question that I want to answer is twofold. From one hand, how the court can find a balance between the medical and the parent's view, which is supposed to reflect the innermost well-being of their child, on the child's best interest, word that I'm going to explain later, and on the other hand, what should improve in the approach of both parties, parents and medical team, and also policymakers, in order to create a collaborative healthcare environment that looks without prejudice at young patients and their needs. I'm gonna also focus on the Children Act 1989, which is a very important piece of legislation here in UK to deal with these cases. And I'm gonna describe first the cases before this act entered into force and the cases afterwards. So we'll see like me bouncing back and forth from cases and legal stuff. The first landmark case before the Children Act 1989 entered into force, and I'm gonna describe these cases without you telling anything about the Children Act, because it wasn't enforced when this happened. So I just want you now to try to see how the judges made up their decisions in those cases. Yes?
Could I just ask, are the slides going to be sent to us at all? Because I can't read the slides and listen to you at the same time.
Of course. On the slides, I just put a few things that might be useful but are not essentials. Of course, I will, yes. And the first landmark case is regards baby Alexandra, who is a newborn with Down syndrome and was suffering from an intestinal blockage, so she needed a surgery straight away to save her life. But the parents didn't want to consent to this treatment because they thought it would be unkind to this child to operate upon her, and probably the best thing was to let her die. For this reason, the hospital made the child a ward of court in order to transfer the care of the baby to the local authority, which eventually authorized the medical treatment, and baby Alexandra survived. Another important case very well known as the Dr. Arthur case, because Dr. Arthur was the gynecologist, the obstetrician in charge of this newborn baby John, who was born with Down syndrome as well. And straight after, he was rejected by his parents. So the parents, in agreement with the doctor, decided to give to the child only nursing care, which meant that the baby should be fed every 4 hours with just water and a morphine-like drug. Those actions, alongside to the fact that the baby developed an infection that went untreated. Fiona, can you please find the charger? I don't know. No, it's not the computer. I don't know where. And unfortunately, the baby died because the infection went untreated. And we know about this case just because a nurse there leaked the information, so the police, the court became involved. However, the idea of the court being involved in this matter was seen by the general public and the parliament something like an intrusion in a very personal relationship between the doctors and the parents. Then we have the Children Act 1989, which is a central piece of legislation in order to protect children in relation to medical treatments, but also children in other settings. This act is very important because it introduced the concept of parental responsibility, which goes hand in hand with the view that the child's welfare, his or her best interest, must be paramount in any related decision-making process. Another terminology which is pivotal within the Children Act 1989 is the concept of severe harm threshold. And this concept has been introduced in the Act to prevent children to be at harm of their parents. In fact, not harm, not suboptimal care. For this reason, the local authority can intervene within the family setting only if it's proved that the child is at risk of harm. Medically speaking, the risk of significant harm in our context now is twofold. On the one hand, the child's life may be at risk since the withdrawal or withholding of treatment may cause his or her death. And on the other hand, carry on with medical treatments with no chance of recovery can pose an unreasonable risk of harm to a terminally ill patient. Let's now look at two cases delivered straight after the Children Act entered into force. Here the judges are trying to deal with this new act and this new legal framework. Again, I'll be quite descriptive because I want you to sense what was going on at that time. The first case is Baby J case. This is a 4-week-old boy who suffered an accidentally fall, and he remained severely disabled. Here, a relevant caveat is highlighted. The court cannot abuse its power to force a doctor to treat a patient contrary to his or her professional clinical judgment. So there is the need to find one who can support the court, either the court or the parents' view. And here the judge, at that time Lord Donaldson, talked about the best possible decision to take. And in order to clarify what best interest might mean in this context. However, the question is maybe how can be considered in the patient's best interest to die? And as unfortunately, Lord Donaldson at that time didn't address this issue at all, and as Joe Bridgman, which is quite an important author on these issues, pointed out, the consequence was that the medical view of disability, of a life not worth living, was accepted rather than tested or challenged, because eventually the court decided that the best course of action was to withdraw all the life-sustaining treatments to Baby J. Another interesting case was Charlotte Wyatt case. Charlotte was a newborn and with severe brain damage, kidney and respiratory problems, because she was born severely preterm. And in this case was very much important and highlighted in the media at that time, because it was quite paradigmatical about how could be so difficult and fragile the relationship between the doctors and the parents, to the point that the judge intervened several times and became like a kind of mediator in this situation, issuing permissible but non-mandatory interventions. So basically saying to the doctor that it was lawful to desist. And another important point raised in this case was that the judge here stressed that the state has the duty to intervene if the child is at risk of significant harm and not suboptimal decisions. And in this case, eventually Charlotte died because it was because her life support treatment was withdrawn. Now we'll move to some most recent cases. Probably you have for sure heard about most of them. I'm not gonna explain all the details about these cases, and I'm gonna address just a few of them. And I'll be quite quick in order to try to, in my conclusion, to highlight all the relevant points that those cases have risen. Charlie Gard is a very young baby with a rare genetic disorder. The parents are adamant to go abroad and offer him experimental therapies, and but eventually they were prevented by doing so. This case is extremely important because it's the first time that the best interests criterion to assess those cases had been challenged before the court, and it's the first time that had been argued that the significant harm threshold should have been more appropriate to deal with those cases. However, here the judge highlighted that try anything may oppose the child's best interest because it may not benefit him, and the question that may arise is whether no benefiting the child necessarily means to seriously harm the child. Michael Wee, writing on this issue, highlighted one very clever point, that futility is not the incapacity to cure. Prolonged life per se is a good if we think that life is an intrinsic good. But then we have to balance the benefits and the drawbacks. Then let's move to Tafida Rakeb case. Tafida is a young toddler with a brain injury, and this case is quite peculiar because it's the only one where the judge agreed upon the parents' requests, and Tafida is the only child still living nowadays. Here, it seems that the sanctity of Tafida's life, the low burden of her treatments, her minimal awareness of her surroundings, and her family's strong commitment to caring for her, all those factors together made the judge conclude that her transfer to a different hospital would have been in her best interest. So the judge here went against the medical opinion and supported the parents. So what was quite pivotal in this assessment was also the fact that Tafida's wasn't experiencing any pain and suffering. So here the judge agreed on the fact that it was possible to offer futile treatments in a way, but as long as those treatments were not painful, and the parents were on board, and the child had minimal awareness of her surroundings. Then we have Pippa Knight. Pippa Knight has a terminal condition, is a very young toddler with terminal condition called acute necrotizing encephalopathy. She went back and forth from the hospital for a long time, and then she falls in a so-called PVS, which is a persistent vegetative state. And here the judge highlighted the fact that the absence of pain is not the same as the absence of harm. So the fact that the child doesn't experience pain, and in this case the medics were pretty sure that was the case, didn't mean that the child couldn't suffer harm. Because there is the concept of harm is not only physical harm as pain, but might be also futile treatments that don't carry enough benefit to the patient. And the problem, not the problem, but the big question was like, why did the medics allow this child to be in pediatric intensive unit in this state for 2 years? Because apparently after 2 years, they said it was enough. And so are 2 years a cut-off time to assess the child's best interest? They didn't realize that there were no improvements before. Another factor, it's about funding and resources. In this case, only the NHS was funding this patient. And the parents didn't have any alternative plan. For instance, in Charlie Gard, all the alternative treatments could have been funded by personal donors' finances. In the case of Tafida Rekeb, she was transferred to an Italian hospital, so then the care was not anymore on NHS. So now I'll try to give you some conclusions and some few points. Both the practical and the theoretical concept of harm inform the child's best interest. So when the judge in Charlie Gard's made clear that the medical assessment doesn't need the formal interference of the significant harm threshold as a new way to intervene in those cases, was because, as we have seen before, the concept of harm already informs the best interest criterion. We heard many times the judges considering the harm for the patients, and the judges consider different forms of harm: pain, futility, low quality of life. But the most interesting thing is that futile treatments sometimes are allowed. So futile treatments are not per se against the child's best interest. But why then? Probably because a holistic and ad hoc assessment of the patient's best interest may embrace factors that together may concur to the protection of her best interest anyway. So we are in front of a holistic approach, which is something we would like to stress more, because I really believe that what we need in this case is an holistic approach, not another terminology to deal with. In fact, convert the best interest into a severe harm threshold probably just would bring us back, maybe not in the same way, to the cases before the Children Act 1989 entered into force, where there was more a focus on parental authority instead of parental responsibility. And probably doing that would mean also to lose this kind of holistic way to look at these patients. But who can be the best, one of the best guarantor of this approach? Probably the parents. I'm pretty sure are the parents. As Mitchell and others suggest, parents have intimate knowledge of their child as a person and significant expertise related to their child's condition as no one else. In fact, many times the doctors rely on the parents' experience of their child's disease. Because of that, because sometimes mothers knows before than others if the child is deteriorating or not. So, why the court has to intervene at some point? The court has to intervene at some point, and it might look patronizing in doing that, because eventually we need a legal scrutiny and clear boundaries. But how those boundaries are drawn or should be drawn? Those boundaries should be drawn in a way that a comprehensive and assessment of the child is guaranteed all time, from the beginning till the end. We have seen that there is this big gray area, which is considerably wider than any black or white. And within this gray area, the Charlotte White case gave us a kind of intuition that probably a mediator is a most wanted figure before going to court, because at the same time, Charlotte White case showed us that the judge cannot be a mediator because it's not an impartial figure there, because it's the one that ultimately is going to take the final decision. So introducing a mediator figure, a clinical ethicist, within the relationship between parents and medical team may be a useful tool, because of course there are ethical committees, but in those ethical committees the parents don't go, are more for the doctors. And as Oakland and Good pointed out, best interest assessment, especially when they relate to how and when it is best for a child's life to end, are not solely medical decisions, nor are they but they are more like a value decision as well. And when it comes to value decision, parents have a lot to say on that. But parents cannot be left alone. They need to be supported. They need to be supported in a psychological, in a logistical, in the communication from the beginning, because they want to engage as protagonists, but we have to offer them the tools to be protagonists, really protagonists. And so I am advocating the presence of all this support from early stage, because what the child needs in that circumstance is having the parents not as spectators to his destiny, but as protagonists alongside the medical team and all the carers. Thanks.
Thanks very much indeed, Ilaria. That was fascinating. I just have a question to kick things off, if I may.
Yes. Yeah.
Is the guard in the British courts, in the English courts? Sorry.
Yes, the English courts.
Does the guardian ad litem have any role?
Yes.
And I mean, it seems to me that, well, maybe I shouldn't say that. I'm going to say it anyway.
Are they fairly limp? Are the guardians at Lighton and the legal teams representing the guardian at Lighton quite limp, because they don't seem to figure much in any of the discussions that I've heard about some of these cases that were very much in the public domain? You know, there didn't seem to be much attention to the representatives of the child in the person of the guardian.
Yes.
Can you tell me about that, please?
Yeah, sure. I don't know if you all know what is a guardian ad litem, but basically when the cases like these are brought before a court, the child is entitled of a legal representative, and the guardian ad litem is the child's voice. And when the guardian ad litem usually his voice is very much in line with the medical team perspective, with the hospital perspective. It's almost, in those cases, I never seen a guardian ad litem saying something which is absolutely different from the position of the hospital. And for this reason, what happens usually is that the guardian ad litem and the medical team become very much a block that confront the parents. And the parents are just, of course, parents' views are taken into account, and parents have the right to say their opinion, their views in regards to their child welfare, but they are just views, no more than that. They are not their child representative.
Okay, thank you. Any questions?
Some of those cases that you talked about were quite high profile. One of them in particular,
yeah.
The Rakim versus Barts Health Trust. Wasn't there some religious and cultural things said about that which you didn't actually say? Am I right in thinking that?
Yeah, I mean, Rakim and also Alta Fischler that I didn't mention. Of course, among the parents' views on their child there is the religion background, and the religion background means also their point of view on life. And of course, this aspect is one of the many aspects that go within, under the umbrella of the best interest. But maybe Alta Fischler, it was even more clear because the parents were Orthodox Jewish, and they asked to the rabbi to explain their view of life, that, for no reason it would have been possible to withdraw treatments, and so on and so forth. But as I said, it's just, of course, the court is going to take in consideration this aspect, but it's not pivotal. In Tafida Rakeb, that of course, I think the parents were Hindu, Muslim, and but probably this was not the most relevant factor. In that case, what made the real difference for the judge was Tafida's minimal awareness of her surroundings and the fact that she didn't experience any pain. So the judge basically in the decision said, I really think bring her to Italy and carry on with the treatments, it's futile. But since there is such a minimal burden, go. And since the parents are on board, because they are the principal carer, and they are so adamant, we can support them. There are the conditions to support them.
So you obviously welcomed that decision in that.
I mean, in a way, yes, because
it respected the parents, and there was minimum burden on the little girl.
yes,
Yeah.
and the fact that, of course, the court cannot force a doctor to act against his or her medical judgment. Fair enough. So why don't we make transfers, second opinions, something more common, something more, in a way, easier to carry out?
Yeah.
Yeah, just related, I wonder if you could just talk me through the background for futile treatments, because I take it that they're not fully futile. I mean, you know, you're not sort of on someone who's got some sort of lung condition, you wouldn't attempt to remove their appendix or something like that. You know, it must be that there's like a small hope, or it's investigative in some way. So what would be? Is there a criteria for it? So it's futile, really just a way to say it's got a very low chance of working, or is there some other medical, is it a medical judgment?
Yeah, I mean, there is no rule written on stone about what a futile treatment is in theory. I mean, we always need to deal with the instant case. In general, a treatment is considered futile if doesn't lead to any change, improvement. We are not saying that the patient has to recover, or no, but we have to see improvements, a change. And in particular, a futile treatment is referred to in treatments that are quite invasive, like artificial ventilations, treatments that can burden the patient. It's not like not doing anything, so it's always a problem of check and balances. But again, and I think it's in a way better not to have a detail of what a futile treatment must be, because it means it's always better to reflect the treatment on the patient. So the thing that that was very hard to understand, for instance, in Pippa Night, was like, carry on with the futile treatments with no improvements for 2 years, and then all of a sudden decide that they were against the best interest of the child. I mean, 2 years? And then, of course, now I'll throw another detail. It was the time of the COVID pandemic also. So in the resources allocation was a huge issue there.
So before you try a treatment, you can't call it futile, because futile is really to do with the response of
Yes.
to that.
Yes.
Right, so yeah, I'm just wondering, not because I think there should be a
Yeah.
specific criterion, but I'm just wondering if that could be added to the sort of purview of sort of parental involvement that you want, you know, in terms of defining futility. For example, you know, parents can often go and research, you know, there's this treatment that they've done over here, it's a very small study, this might not be something that other doctors are aware of, whatever. So they can make a case against the futility of something. Oh, look, there's some
Charlie Gard.
yeah, exactly. Yeah.
Charlie Gard. But then eventually, the doctor in Charlie Gard, eventually the doctor who proposed this pioneering therapy for eventually when he changed his mind at some point. So again, it's always quite hard to strike a kind of balance, but yeah.
Thank you.
If I heard you correctly, that we need to bring in the parents of the children into the whole care of the child. It's how do you propose that parents begin to appreciate medical terminologies, and in terms of communication, what would you propose in terms of communication, understanding some of these medical terminologies, procedures? Because I think that is one barrier that can, really affect their involvement in the care. Okay. So the second one is the question you asked about the voice of the
Child.
I know that it's kind of like even it can become another research for you if you want to look at it. What do you think? What would you propose? In solving that challenge, because it's a challenge. I mean, for me to be hearing that, I must say that this is the first time I have heard it, because I can't understand why with all the cases, this representative's voice is similar to the medical teams. I mean, I still can't understand. Maybe there is some. Is there some alliance between the two? I don't know.
In regards to the first one, most of the cases don't go before a court, and only a very minority goes. So usually parents and medical team are able to work together. Okay, of course, when it comes to life and death decisions, it becomes emotionally very, very, very much demanding. For this reason, what I would advocate is the presence of a clinical ethicist, a mediator, who facilitate the communication between the two parties, but being truly impartial, because it cannot be just the medical team that needs to be legally backed up. Neither the parents that have to try anything no matter what. Because when it comes to these two polarities, we have already lost the child. So, and of course, when I also thought about supporting the parents from early stages in terms of communication, logistics, all can concur to create an environment that it's not hostile. About the guardian ad litem, it's always, we can say the same about the judge. Why the judge is always in line with the hospital? Because the judge is not a doctor. the judge can try to grasp idea, concepts, views, but ultimately it's not his job. The guardian ad litem, of course, has to say how a toddler feels in that situation. I mean, it's like it's an impossible job. And so he's gonna say what the medical team is saying, that probably is suffering. Yeah, probably suffering. I mean, you know.
Thank you very much indeed.
Thanks.
Helen.
Oh, sorry, no, there's one more question.
Yes,
Helen.
yes.
Oh, sorry.
Sorry. Oh, I thought Helen was coming here. Sorry.
You don't want to hear my question. Well, just a quick comment, please. I suppose what you could say is that the judge is not a doctor, but the judge should have some kind of a grasp of what counts as a good reason for stopping treatment,
Yes.
as opposed to a bad reason.
Yes.
So the judge can look at what can look at the medic's representations and say, well, you know, this is about balancing burdens and efforts of treatment, that's fine, okay, the judge can say that. It could say that in one case, and in another case, maybe the judge can say, I'm not convinced that the motive here is not a euthanasia motive, as in, you know, I'm not convinced that the medics aren't actually intending the child to die when they refuse a particular treatment. And so, you know, without being a doctor, that's something that the judge can contribute. In fact, the most important thing that a judge can contribute, are the medics trying to withhold something for a good reason, or are they trying to withhold something for actually you might even say a homicidal reason?
Well, I think that I don't think that in a way no one is withholding anything. I mean, before the court is going before the court is actually the only moment in which all the parties can put everything on the plate. And then the judge has the hard job to do check and balances. The thing is that usually the judge has to do this in a very short period of time, because it's always like a matter of life and death. So, but often he visits the child in hospital to get a better sense of the family, the condition. I think what the judge misses very often is that there is an holistic approach that needs to be taken at that level as well. Since we don't have intermediate levels, because we have either parents and medical team that they agree on something together, or a judge who takes the decision on behalf of the parents. We don't have anything in between, and so what I think it's the judge tend to lose when the case goes before him is this holistic view, which is both medical and value-based. And he tends to go for the first one because probably is the most straightforward. But it's a gray area. And I think it's very hard to take a decision at 360 degrees within gray areas.
Okay. Thank you.